Ladies and gentlemen, today I'm going to continue from the previous talk and talk about how laboratory medicine itself has responded to the COVID-19 pandemic. It's difficult to believe that not that long ago, only the 31st December 2019, that the Wuhan Municipal Health Commission reported a cluster of cases of pneumonia in the Wuhan area. This rapidly became of importance, and on the 3rd of January, the following day, WHO set up an instant management support team. Only 10 days later, WHO went on further to issue a comprehensive package of technical guidance. And 3 days later, the first case of COVID-19 was reported in Thailand, the first recorded case outside China. And soon, within the year, the entire world had the COVID-19 infection. No part of the world was exempt from having this devastating disease. And looking at this on the 10th of December, a few days ago, we can see that there were about 267 million confirmed cases of COVID-19, and very unfortunately, about 5.3 million deaths from this disease. But we are getting our own back. We are fighting back this virus, and now there are over 8 billion administered vaccines to people worldwide. But so how has science responded to this COVID-19 pandemic? Well, the COVID-19 pandemic was identified, the WHO declared a pandemic, and science kicked off and started working on this. On the clinical side, our clinical teams looked at the development of new treatments for this disease, and also investigated current medication to see if they could have any value in combating this infection. And also, there was rapid development of vaccines. I don't think any of us could have believed before this pandemic how quickly these vaccines could have been developed. At the laboratory, we fought this disease by developing PCR methods. We developed point-of-care antigen detection methods. I went on to develop an expanding number of testing centers where people could be tested and have their viral position assessed. And manufacturers very quickly developed qualitative antibody methods against COVID-19. And very, very rapidly after that, went on to develop quantitative methods for measuring this antibody. And these quantitative methods, of course, can be used to assess the effectiveness of the vaccine program. So when I look at COVID-19 and the laboratory, I can think of it in two ways: a direct effect in the laboratory and the indirect effect on the laboratory. Let's well consider first the direct effect in the laboratory. Well, as I've already said, very early on in the disease progression, we can look at molecular testing. We can actually assess whether somebody is infected or not. And we can also assess what kind of variant that individual has. I will maybe come on to that a little bit later on. And these molecular tests basically are real-time polymerase chain reactions. And this is the method we use here at the Norfolk and Norwich University Hospital. A complex array of techniques eventually coming to a point where we can identify whether an individual is infected with SARS-CoV-2 or is not. And also, with an extension of this technique, we can identify what kind of COVID-19 disease or what variant that individual actually has. So within this pandemic, laboratories in the UK and worldwide have rapidly developed SARS-CoV-2 real-time PCR methods. This is achieved by either adapting methods already being used in those laboratories or developing methods in laboratories that have not previously performed this test. It's remarkable how quickly laboratories managed to perform this investigation. We also developed a sample collection network, testing centers. And these testing centers had the requirement to take samples from a large number of individuals very rapidly, to accurately collect data from people turning up and giving samples, labeling and packaging the samples. And this, as you can imagine, involved a lot of training of a large number of individuals and a system of rapidly transporting these samples to laboratories for analysis. And then when results were available, fast and efficient reporting of the results back to individuals, and to track and trace anybody these individuals may have had contact with. So we had the PCR methods for looking at the viral loads. Then we went on to measure and introduce antibody methods. And these antibody methods are raised either against the nucleocapsid protein of the virus or against the spike protein. These immunoglobulin methods are measured slightly later on in the disease process. The IgM reaction is a reaction that occurs first, followed by the IgG. And the IgG reaction has a longer lasting effect than the IgM, which falls off relatively rapidly. So you do the right test at the right time. We can do the molecular testing early in the stages of disease progression, and sometimes even before people actually show any clinical symptoms. And then we can monitor the progress of disease, or indeed the progress of people who have been vaccinated against disease, to see how the antibody levels are maintained and give continued protection against the virus. Indeed, it's remarkable how manufacturers managed to very quickly introduce initially qualitative methods for the immunoglobulins, and very rapidly following that, quantitative methods. And we can see here a method for the quantitative measurement of SARS-CoV-2 immunoglobulin G from Abbott Laboratories. You can see the amazing imprecision that can be achieved with these methods. Less than 5%, which is very, very acceptable. And the sensitivity and specificity of these methods were almost 100%, showing very, very limited cross-activity with any other respiratory infections, and almost 100% reliability in showing whether patients were truly infected or not. And the good things about these methods, they also measure the immunoglobulin response to the various variants that followed on from the Wuhan initial strain. We don't know yet with the new strain going round, but I would suspect we will see a similar kind of increased measurement with the new variant, as well as we saw with the older variants. So we can be quite happy in a way that we are detecting the immunoglobulins from the different variants that we are seeing. The worrying thing is that there is little or no concordance between the different methods that are available currently on the market. We see that the current anti-SARS-CoV-2 antibody methods do not compare well with each other in terms of the units of measurement, linearity, magnitude of response, and the relative response in different patient samples. The methods that detect either the spike protein tend to have better concordance than those that are compared to the nucleocapsid part of the immunoglobulin. This may be This may be due to the calibration of the methods, but it is likely that we'll never see full calibration when the different parts of the protein are being targeted to the immunoglobulin. The materials candidate available, the candidate primary reference material, show considerable variation across the methods, and these had to be improved. If this isn't done, then the quality of this reference material, including the description of the antibody population within the reference material, will result in a poor level of agreement we will see across the different method groups, and we will fail in harmonizing these as we have for a number of other serological methods that we've worked on. So we've got the molecular testing followed by the immunoglobulin testing. And then we have to go on to actually do our laboratory testing we would normally do in these patients to ensure that they remain as healthy as possible. So I can now look at the indirect effects of COVID-19 on the laboratory. It is a very unfortunate fact that COVID-19 has a far more devastating effect on the older populations. And the older you are, the increased risk of death. So patients, especially older patients, and those with chronic conditions, avoided coming into healthcare. And this had an effect on our ability to monitor the health of these individuals. If you can look at the adult and pediatric diabetic clinic here at the Norfolk and Norwich, 100% of patients moved to video consultations. This continued for 12 months. People with diabetes and other patients shielded not coming to clinical settings. And parents were reluctant to allow children with diabetes to visit the hospital. This resulted in increased use of point-of-care testing in outreach clinics to measure hemoglobin A1C. Indeed, point-of-care testing came into its own during this pandemic. Also, we looked at new ways of collecting and delivering samples to the laboratory to allow patients not to come into the healthcare setting. How does it affect our number of samples? Well, in this laboratory, pre-pandemic, we were handling about 1,500 samples every weekday for hemoglobin A1C. During the pandemic, hemoglobin A1C requests fell to less than 100 samples every day. Why is this important? Well, as I've already said, as patients get older, the increased risk of dying from COVID-19 increased. But as you can see here, if you had type 1 or type 2 diabetes, there was an even greater increased risk of death as you get older and at every age point along the scale. And if you look at this, some data from Emma Barron and group here, we can see that type 1, type 2, and other type 2 diabetics had increased risk of death in this population studied. Why was that? Well, again, looking at some data from Emma Barron's group, you can see that in type 1 diabetes, as hemoglobin A1C levels increased, there was an increased risk of death. In type 2 diabetes, again, as hemoglobin A1C levels increased, there was an increased risk of death. And this was even more significant than in type 1 diabetes. So it's important to measure hemoglobin A1C. We must not stop measuring it. Again, we can look at dexamethasone. First drug clearly demonstrated a value in patients with COVID-19. However, we know that high-dose glucocorticoid therapy increases the level of hyperglycemia, especially in sepsis and inflammation. And glucocorticoids are the most common reason why people with COVID-19 and diabetes develop life-threatening hyperglycemia. Hemoglobin A1C measurement is important. And this led other people to actually looking at different ways of actually measuring this without the patients coming into hospitals. And here in this group of researchers, looked at supplying kits for collection of sample in people's homes, and they could post these back to the laboratory for investigation. And we found the compliance rate was actually very high. 73% of kits were returned. And if we exclude people who didn't return the kits for good reasons, like they're out of the country or they had a recent hemoglobin A1C, the return rate was 87%. So this was very effective. And all the results, apart from one, or so all the samples, apart from one that were returned, were successfully analysed. And people found this a very convenient way of doing things. And the cost was actually quite reasonable. So this was a useful way of actually getting samples from people in the community to have hemoglobin A1C measured. But it's not only hemoglobin A1C. This group here from Northwest London looked at using a similar kind of collection device to measure other parameters in the laboratory, and found that apart from a small number of parameters, they could successfully measure a whole range of analytes. And again, patients who returned this way found it to be very satisfactory, and they would recommend this means of analysing to other patients. To finish off with, there was an audit, a national audit performed by David Hounsley on behalf of WEQAS organisation here in the UK, and asked several questions. Most of the responses came from district general hospitals, but there are a number of teaching hospitals there as well. And he asked the question, did you deviate from your quality management system at any point during the pandemic? And actually half of individuals said yes, they had. Did you opt out of processing and return results to EQA? Again, almost half of them said, just over half of them said they had. And why was this? Well, most of them are actually from point of care devices. And when we looked at the reason why this happened, you could see that it was due to accessing these point of care devices by the laboratory staff. The next question, did you verify any new methods for the purpose of managing COVID patients? Well, yes, many did. 75%, almost 75% did have new methods. These methods were either IL-6, pool calcitonin, molecular, or other antibody methods, but also the introduction of point of care devices was also important. And it goes on to ask, did you take on any new methods of local verification? Most people did locally verify them, but most of them did not follow the usual protocol for method evaluation. And these are a whole range of different reasons why they didn't do it. Not as many sample comparisons, interference studies were not done, imposition studies were not done. So there was a number of things we could have done better. Did utilization and location of point of care devices change? Well, yes, a lot of them did. And was the laboratory involved in the moves? Again, they were mainly. But we identified a number of problems that occurred when these things moved. And one of the main problems was the increased use of untrained users. So in conclusion, widespread changes across healthcare as part of the response to the pandemic. We changed the way we provide medical care in a way that we could never have thought of pre-pandemic. Laboratories themselves were both drivers of change and responded to requests to change. Early indicators of deviation from usual QMS practice what have been seen. Was this justified or not? Something we can discuss and consider. But generally, overall, laboratories can be applauded for their response to this pandemic. Laboratories rose up to the challenge, and overall, laboratories have done an incredibly good job. Thank you.